Hello, welcome back. Today we are going to discuss about type 2 hypersensitivity reactions, and our learning outline we shall begin by introduction and definition of key terms in relation to type 2 hypersensitivity reaction. We shall discuss the pathophysiology of type 2 hypersensitivity reaction, the clinical presentations of different type 2 hypersensitivity reactions, and then we shall end up with the how type 2 hypersensitivity reactions can be diagnosed and treated. A hypersensitivity reaction is an exaggerated immune response to what should be considered harmless environmental antigens, and type 1, type 2, and type 3 are also known as immediate hypersensitivity reactions, as they can occur within 24 hours, while type 4 reaction is also known as delayed hypersensitivity reactions, as it occurs after several days following exposure to an antigen. Type 2 hypersensitivity reaction is mediated by immunoglobulin type M and type G, and these immunoglobulin antibodies bind to intrinsic antigens, that is, antigens within the host, or extrinsic antigens, that is, antigens coming outside the host. Examples of intrinsic antigens may include the red blood cells, the basement membrane of some body structures and tissues. In addition to that, the examples of the extrinsic antigens may include the blood products of transfusion. So these immunoglobulins type G and type M bind to these either intrinsic or extrinsic antigens, and they tag them, and by tagging them, they are making them to be detected by the immune system, and when the immune system detects them, it ends up attacking them or destroying them or causing various effects. Following binding of antibodies and antigens, cell lysis, tissue damage, and dysfunction occurs through the following mechanism. As we have discussed, when these immunoglobulin type G and type M bind to the antigens, either the extrinsic antigen or the intrinsic antigen, the cell lysis, tissue damage, and even tissue dysfunction may occur. And the major three mechanisms involved in the destroying, altering the function of the cell, and even causing tissue damage are activation of the complement system, antibody-dependent cell-mediated cytotoxicity, that is ADCC, and antibody-mediated cellular dysfunction. All these are the mechanisms through which the immune system destroys the target cell after it has been tagged by the immunoglobulin M or immunoglobulin type G. We are going to discuss each mechanism in detail in the presentation and slides to come. Let's start with activation of the complement system. So when the immunoglobulin type G and type M bind to a given antigen, which can either be extrinsic or intrinsic, there is they interact with some types of complement proteins. And when, for example, the antigen antibody complex has been formed and comes into interaction with the complement protein type 3, it causes activation and cleavage of this complement protein into 3 molecules, that is C3A and C3B. So the C3B causes cleavage, or it also C3B further breaks down another complement protein known as C5 into C5A and C5B. So after various cleavages and activation of the complement proteins, these complement proteins act in various ways to cause an immune reaction and destruction of the target cell. For example, complement protein 3A, C4A, and C5A mediate inflammatory, or they are also known as anaphylatoxins. They cause mast cell and basophil granulation, and causing release of granzymes that consequently perforate and destroy the target cell and digest the contents of the target cell. They may also C5A, complement protein type C5A, may also cause neutrophil chemotaxis, and neutrophils are also important. Neutrophils are important in phagocytosis of target cells, or a cell that is maybe has been tagged by the immune system for destruction. Complement proteins C5b, C6, C7, C8, C9, they form the membrane atta complex known as MAC, and this MAC binds to the cell surface membrane of the target cell. They cause a rapid influx or alteration in the ion channels, and there is an influx of ions into the cell. And influx of ion is always accompanied by osmotic movement of water, and this results in osmotic changes and cause cell lysis due to excessive fluid overload and bursting. Complement protein C3b is an opsonin, and it binds the cell and tags it for elimination. It tags antigens for elimination by phagocytes, mediating phagocytosis of target cell. For it, when it binds to target cell, it attracts phagocytes, which eventually phagocytose the target cell, hence destroying it. Examples of type 2 hypersensitivity reaction that utilize activation of the complement system include transfusion reaction and autoimmune hemolytic anemia. All these occur following the mechanism of activation of complement system that results in target cell death, dysfunction, and destruction. Our second mechanism is antibody-dependent cell-mediated cytotoxicity. And the mechanism behind this is that antibodies bind their antigens, and after binding to them, they tag them for phagocytosis. As we had discussed in the previous slide, that for example, complement protein Ty3b binds to target cell and then tags it for phagocytosis. Likewise, antibodies like C3b bind to the target cell, and then when they have bound to it, they tag it and then attract phagocyte cells that eventually engulf and cause destruction of the target cell. And if antigen and antibody complexes are too large to be phagocytosed, or they cannot be phagocytosed by the neutrophils, the macrophages, natural killer cells are recruited to do the work. Still, the opsonins or the antibodies will target the target cells, and if it is too large, the natural killers will be recruited, and then they will eventually perforate and kill the target cell. How do the natural killer cell do the work? They bind to the target cell, and then after binding the target cell, they release granzymes, and these granzymes perforate the cell membranes of the target cell, resulting in cell lysis. And examples of antibody-mediated cytotoxicity mechanism of type 2 hypersensitivity include transplant rejection, immune reaction, and gas neoplasm. All these use this mechanism to cause cellular dysfunction, cell death, and tissue cell lysis. Second, type 2 hypersensitivity reaction. More so, another type mechanism is known as the antibody-mediated cellular dysfunction, and here the antibodies bind to the target cell or target tissue, and they do not cause any harm. They do not destroy it, they do not kill it, or they do not cause inflammation in any way. But what they do, they cause dysfunction, and dysfunction can either be hyperfunction or hyperfunction. They just impair the usual function of that given target cell. And in other words, the cell keeps intact, it is not affected, but its function is impaired with. And most times the antibodies bind the target cell surface receptors, and they cause abnormal activation or blockade of the normal cellular signaling process of the target cell, and hence the functionality of the target cell is impaired with. Examples of antibody-mediated cellular dysfunction include myasthenia gravis, where antibodies block acetylcholine receptors, Graves' disease, where antibodies cause stimulation of the thyroid-stimulating hormone receptors on the thyroid gland, and pernicious anemia, where antibodies are formed and act against the intrinsic factor. What are the clinical features of hypersensitivity reaction? Clinical features are different depending on the exact cause of the hypersensitivity reaction and the exact target cell affected by the type of hypersensitivity reaction. For example, in the transfusion reactions, that is in blood group AB or incompatibility, the patient may present with fever, itching, urticaria, and then serious reaction may result in respiratory distress and eventual hypotension. While on the other hand, in autoimmune hemolytic anemia, where antibodies are being produced against red blood cells, which is always mediated by immunoglobulin type G or type M, the patient presents with weakness, shortness of breath, pallor, and then more so, the patient may have jaundice, icterus, and dark urine, and this is always due to excessive hemolysis that results in excessive accumulation of bilirubin in blood, causing the effects observed clinically. In pernicious anemia, where the antibodies are being produced against the intrinsic factor, these antibodies prevent absorption of vitamin B12 and cause vitamin B12 deficiency. Why? Because intrinsic factor is very critical and very vital in the absorption of vitamin B12. So when the antibodies are being acting against the intrinsic factor, it means that the rate of absorption of vitamin B12 will be impaired with. And clinically, the patient presents with the general symptoms of anemia, plus other symptoms such as glossitis, paresthesias, and gait problems. In hemolytic disease of the fetus and newborn, where antibodies are produced against red blood cells secondary to rhesus factor incompatibility or rhesus D incompatibility, in the first pregnancy, a rhesus negative mother will carry the pregnancy of a rhesus positive fetus, and the labor will be normal. However, there will be leakage of the fetal red blood cells into the mother's blood, and postpartumly, the fetal red blood cells may survive long enough, and as a result, they may stimulate and initiate an immunoglobulin type G response as a result of the incompatibility. And in the second pregnancy, the maternal antibodies cross the placenta and attack the fetal red blood cells of the second rhesus positive fetus. Like in summary, first pregnancy, a rhesus negative mother is carrying a rhesus positive fetus, and what happens during the labor period, there is that kind of cross matching or mixing of the fetus blood with the maternal blood, and after that, the maternal blood detects presence of rhesus positive antibodies which are incompatible with the mother's blood, which is rhesus negative, and as a result, immunoglobulin type G are recruited and they keep in the body of the maternal blood as memory cells, awaiting a future kind of reaction, and then that in order to respond accordingly. So when it happens that the mother again becomes pregnant and again is carrying the rhesus positive fetus, there is a light likelihood that now this will trigger an immunological response, since the initial memory cells, that is the immunoglobulin type G, are still intact and are in circulation in the body. This will be activated, and as a result, they will cause lysis of fetal red blood cells and resulting in clinical manifestations in the fetus, such as self-limiting hemolytic anemia in the fetus. That is when the anemia is not so severe. The fetus may have features of anemia that can always be observed clinically, that is pallor, tachycardia, all those can be observed in the fetus. However, in severe cases, that is hydrophytalis, the fetus may have severe anemia, skin edema, ascites, pulmonary or pericardial effusion, and all these are secondary to the adverse lysis of red blood cells, secondary to the anti-D incompatibility. Our third clinical condition is the autoimmune thrombocytopenic purpura, and it occurs when the phagocytes destroy sensitized platelets in blood, and increased risk of bleeding occurs when the platelet count is less than 20,000 per microliter, if most of the platelets has been destroyed, to the extent that the platelet count in a peripheral blood smear is less than 20,000 per micrometer, the patient is at high risk of increased bleeding in case of any injury. And patients normally present with petachia, pupillar, epistaxis, and severe hemorrhage, since platelets are the major components used in platelet flag formation and coagulation. So their absence or their inadequacy may have severe effects and severe abnormalities or impaired coagulation. In acute rheumatic fever, which is also under type 2 hypersensitivity reaction, antibodies are produced, and these antibodies act against the cell wall of streptococcus, which is the foreign microorganism that is causing infection. So the body tries to respond immunologically in the normal immune reaction to fight against the streptococcus, and they produce the anti-M antibodies, which are always against the M proteins of the streptococcus, of the streptococcus aureus, of the streptococcus bacteria. The cell wall of the streptococcus has M protein. So when the streptococcus infects the human body, the immune system detects the M proteins or the antigens, which are the M proteins on the cell wall of the streptococcus. Following detection, the immune system releases antibodies against the M proteins of streptococcus, and as a result, some body structures have antibodies that resemble the M proteins of the streptococcus, and these may include the myocardium, they may include the joints, and so as a result, as the immune system is doing a massive destruction of the M protein containing structures, that is the streptococcus, it ends up accidentally invading and destroying target host cells, that is the myocardium and the joint structures. And clinically, the patient presents with arthritis second to damage of the joints, carditis second to damage of the myocardium, Sidonia chorea, subcutaneous nodules, and erythema marginatum. In Goodpasture syndrome, antibodies attack in the basement membrane of the alveoli, resulting in pulmonary hemorrhage, and in the kidney, resulting in nephritis. This is where the body produces antibodies that destroy the basement membranes of the alveoli and the kidney, resulting in nephritis and pulmonary hemorrhage, respectively. Initially, the patient presents with systemic complaints, followed by renal complaints, that is hematuria, and pulmonary symptoms, that is dyspnea and hemoptysis or cough. And in Graves' disease, as we had discussed earlier, thyroid stimulating hormone receptor antibodies stimulate the thyroid gland, produce free thyroxine and T3, so without stimulation of the thyroid stimulating hormone. Clinical features: the patient may have goiter, exophthalmos on examination, and clinically, the patient may also have symptoms that are associated with these examination findings, such as heat intolerance, anxiety, tremors, palpitations, and weight loss. In myasthenia gravis, this is where the antibodies inhibit the binding of acetylcholine to nicotinic acetylcholine receptors, and as a result, there is impaired signal transduction, especially in the skeletal muscles, and in addition to that, these antibodies also activate the complement-mediated receptor destruction. They cause destruction of the target receptors to which they are bound by the complement system, as we had discussed in the mechanisms in the previous slides. And clinically, the patient presents with fluctuating muscle weakness that is worse at the end of the day or after exercise. The patient may also present with ptosis and diplopia. In addition to that, the patient may have fatigable chewing. The patient may not be able to chew for long, and he or she may also have limb weakness, respiratory muscle weakness, and when it is severe, it may lead to respiratory failure, which is also known as myasthenia crisis. How all these clinical conditions we have just discussed managed, and how are they diagnosed clinically and then managed? Of course, diagnosis and management of these numerous clinical conditions depends on what you're observing clinically and which organ systems are being involved and how is it severe, like how are these specific systems being compromised with secondary to this type of reaction. In transfusion reaction, diagnosis is always made by clinical judgment, that is from history taking and examination. And in addition to that, a very important investigation that would also aid in diagnosis is Coombs test, whereby a positive Coombs test confirms hemolysis and thus confirming the transfusion reaction. And management, as we had discussed, management is complete detailed management of transfusion reaction. It has been discussed in one of our PowerPoint presentation, that is on blood products and transfusion. You can go out and look for it. However, general management, you should stop the transfusion and you do again blood grouping and cross matching to determine what could be the cause of the transfusion, and then you do supportive care, prevent disseminated intravascular coagulopathy, as we had seen in transfusion reaction. There's activation of the complement system, and this has effects that can cause DIC. In autoimmune hemolytic anemia, diagnosis is to do the hemolysis workups and the Coombs test, and management, first line of management for autoimmune hemolytic anemia is through administration of glucocorticoids, as this reduce on the severity of inflammatory reaction, as these are anti-inflammatory drugs. They reduce on the severity of inflammatory reactions, and from there you can treat the underlying cause. And for refractory cases of autoimmune hemolytic anemia, immunosuppressive drugs would be recommended, or even splenectomy would also be recommended. In pernicious anemia, where antibodies are being produced against the intrinsic factor, diagnosis would be through CBC, and then more so that is assessing the level HB, and assessing the size of RBC through assessing MCH, MCHC, and from there it's also, you can also assess for your assess for the serum vitamin B12 levels and the serum folate levels through doing blood chemistry tests. And management is through vitamin B12 supplementation. In hemolytic disease of the fetus and newborn, diagnosis through pregnancy, history taking to know whether this was the first pregnancy or the second pregnancy, in order to be sure if indeed it is a hemolytic disease of the newborn. You can also assess chemistry, blood chemistry, and assess the maternal antibodies. You can do ultrasound and you can do fetal labs. Prevention is administration of anti-resus at 28 weeks of gestation and then within 72 hours before delivery. In autoimmune thrombocytopenia pupilla, diagnosis is also through clinical, that is through profile history taking, and then after you can also do complete blood count, peripheral smears to assess for the number of platelets per microunit. You can also do screening for other conditions that could also be confused with platelet thrombocytopenia, that is hepatitis C, HIV, and other tests that are also relevant in relation to the history taking or the clinical symptoms the patient is presenting with. And management is to prevent as much as you can the bleeding, the incidence of bleeding clinically. In addition to that, if a patient is already presenting with bleeding, platelet transfusion may be advised, or administration of intravenous immunoglobulin or glucocorticoids. In acute rheumatic fever, diagnosis is through assessment of the serum C-reactive protein levels. You can also do the erythrocyte sedimentation rate, and you can also assess for the serum anti-streptolysin, or you can also use clinical judgment and plus the clinical findings, examination findings, and the lab investigation. You can use the Jones criteria, as we shall discuss in one of our presentations, to know whether the patient is having acute rheumatic fever or not. Management of acute rheumatic fever is through administration of antibiotics for streptococcus and through giving supportive care for the specific clinical manifestation of the patient. Management of the Goodpasser syndrome, first of all, diagnosis is through assessment of labs, that is anti-neutrophil cytoplasmic antibodies, anti-glomerular basement membrane antibodies. You can also do renal biopsy to assess the rate of damage to the kidney nephrons, and management is plasmapheresis and immunosuppressive therapy. In Graves' disease, diagnosis through assessing the serum TSH receptor antibodies. When they are high, that immediately confirms the presence of Graves' disease. You can also do thyroid function test to confirm whether they are elevated T3 and T4 levels. Treatment is through systemic control, that is administration of beta blockers, or reduction of the thyroid hormone synthesis by the thyroid gland, that is through administration of the antithyroid drugs, radioiodine, or through thyroidectomy, which can either be total or subtotal thyroidectomy, depending on the clinical judgment. In myasthenia gravis, a single fiber electromyography can be done to diagnose, and this is the most sensitive test for myasthenia gravis. And management is through administration of predostigmine or administration of immunotherapy, or through thymectomy to remove the thymus gland, which is always important in tagging and sensitivity of the T3 and of the lymphocyte, the T lymphocytes. And so their removal means that the extent of production of these lymphocytes, the T lymphocytes, and tagging them for specific immunological functions may be reduced, and so helping counteract the effects of myasthenia gravis. Thank you. This marks the end of our presentation. Thank you for bearing with me. Thank you for being with me along the way. I hope to listen from you guys. Comment in the comment section, and give your insights, add us more insights, and discuss with us and make the journey more awesome. I hope to see you soon in our next presentations. Good luck to you.